Thank you, Mr. Chairman. Hope is not a plan was the admonishment we received from the gentleman from Massachusetts. It is perhaps also a fitting title for the obituary of the last 8 years. Time and again, we've heard our Democratic colleagues on this committee say there is no replacement, there is no plan that Republicans have offered. And whether they're here with us or back in their offices admiring their names on the wall, I would suggest that they look at the legislation offered by Mr. Rokita, where he has said that if we functionally block grant Medicaid to the states, then we can experience the great vibrance of a federalist system, where best practices will be attempted and copied. And sure, there'll be some who miss the mark, but that's sort of the deal we get in a constitutional republic, and I certainly join Mr. Rokita in attempting to advance those efforts. I want to, for a moment, speak about emergency room visits. There was a promise in Obamacare that we would see a reduction in emergency room visits, but I've noted a 2015 study from Northeastern University suggesting that emergency room visits post-Obamacare in Illinois are up. Another 2015 survey from the American College of Emergency Room Physicians, where 3 in 4 emergency room physicians are experiencing higher emergency room volume, not lower volume, following Obamacare, and a February 2016 study from the Center of Disease Control suggesting that there's really been no reduction in emergency room visits as a consequence of this law. And so I guess my question for Dr. Blumberg is, why has Obamacare failed to reduce the number of emergency room visits?
Well, first of all, I think it's not fair to assume that any change in emergency room visits is inappropriate use. So in some areas you may have there are always provider shortage areas where people tended to use emergency room care more. Those provider shortage areas were prior to the ACA and they still exist.
Sure.
But in addition, when you see an increase under the Affordable Care Act, what you're doing is you're lowering the price of medical care to people. And so people who couldn't afford necessarily to go and get an emergency room care when they needed emergency room care now have financial access to do so. So it's not necessarily just because you see an increase that's an increase in inappropriate use.
Reclaiming my time, I'm glad you mentioned that. So let's then turn to the state of California, the state that has perhaps most enthusiastically embraced the expansion of Medicaid, where currently 1 in every 3 Californians is on their Medicaid product, 13 million people. Across the board, reductions in reimbursements to providers. We read in the Los Angeles Times the story of Kevin Hill, 58 years old. He was one of these Americans who was added to the Medicaid rolls. He had to call 15 doctors in the Long Beach area. Either the doctors weren't even answering their phones, or they weren't taking CalMed patients anymore because reimbursement rates were so low. And where did Mr. Hill end up? Back in the emergency room. So I guess, you know, the question is, if you've got a circumstance where you've got enrollment that is spiking beyond the ability to raise taxes to pay for it, and reductions in what we pay providers, what is the hope looking forward?
Well, I think we shouldn't make our public policies based on anecdote, and I do appreciate the story of your one constituent, but there's a lot of people who are getting Medicaid coverage now who have a usual source of care, and we can demonstrate this through household surveys that never had a usual source of care before, and that's
Dr.
outside
Lumberg,
of the
reclaiming my time,
room.
you know, it's sort of like shifting ground when I cite the statistics that indicate that there's rising participation in our emergency rooms. The statistics can't be trusted. When we cite the individuals who cannot go and obtain care, then we can't trust the anecdote.
But I did say when you lower the price of medical care, more people have access to use it. But that doesn't mean we aren't also increasing access to usual sources of care for people who are uninsured for the first time under the Medicaid program, because the evidence is very strong that we are.
Well, then let me conclude my time with some bipartisan agreement with the gentlelady from New Mexico. I agree wholeheartedly with her statements that we have real cost problems and cost drivers, I think frequently aided by a hospital industrial complex and an insurance system that, for the most part, has been supportive of the Affordable Care Act and does not want its repeal. And so the very people that the Democrats on this committee criticize for being the drivers of cost are the very same entities that are bellied up to the trough, draining resources away from those who are truly vulnerable. And so I join the bipartisan sentiment about trying to attack those cost drivers, but it seems as though focusing only on coverage, which is illusory, which doesn't lead to real care, and just leads to more folks in the emergency room, is not the better way that we should all be pursuing.